Hello guys, nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Fleischner Society 2024 Glossary of Terms for Thoracic Imaging, Part 2. Let's go! Fleischner Society 2024 Glossary of Terms for Thoracic Imaging. This topic is for you. Radiology, Reviews and Commentary, Statements and Guidelines, Fleischner Society, Glossary of Terms for Thoracic Imaging, Alexander A. Bankier et al., Radiology 2024, 310. Aortopulmonary window anatomy. The aortopulmonary window is a mediastinal compartment delimited anteriorly by ascending aorta, posteriorly by descending aorta, cranially by aortic arch, caudally by left pulmonary artery, medially by the trachea and the lateral wall of left main bronchus, and laterally by medial pleura covering left lung. The AP window contains lymph nodes and connective tissue and is traversed by left phrenic nerve, left vagus nerve, left recurrent laryngeal nerve, and left bronchial arteries. It is separated into a medial and lateral part by ligamentum arteriosum. Aortopulmonary window anatomy. The arrows indicate aortopulmonary window, and the last one is showing us enlarged pathologic lymph node of AP window, number 5 lymph node of metastatic state. Apical cap pathology. Apical caps are cap-like rims at lung apices, often bilateral, usually caused by pulmonary and/or pleural fibrosis displacing extrapleural fat, chronic ischemia causing a plaque of elastotic fibrosis of the visceral pleura with or without subpleural lung parenchyma has been suggested as potential pathogenesis, which is variably associated and aging. In addition, apical caps can be caused by fluid collections associated with infection, neoplasms, or trauma, either extrapleural or within the pleural space. A left apical cap can be caused by hematoma, such as resulting from aortic rupture. Moderate or severe apical pleural caps also can be seen in upper lobe fibrosis, including pleural parenchymal fibroelastosis. Apical cap pathology. The arrows indicate apical cap. Architectural distortion pathology. Architectural distortion is characterized by defocal or diffuse derangement of the normal pulmonary anatomy, with abnormal displacement or disruption of airways, vessels, and interstitium. It is typically accompanied by volume loss and is commonly seen in fibrotic lung diseases. Architectural distortion pathology. Arrows indicate the architectural distortion in thin section lung window settings of ILD patients. Asbestosis pathology. Asbestosis is an occupational lung disease characterized by lower lobe dominant pulmonary fibrosis caused by inhalation of asbestos fibers. Once established, fibrosis can progress. However, even without progression, the risk of lung cancer is increased. In addition, asbestos exposure increases the risk of mesothelioma. However, asbestosis is usually associated with high levels of asbestos exposure, in distinction to mesothelioma. Although pleural plaques, calcified or non-calcified, may also be identified, their presence is not essential for the diagnosis. Aspiration pathology. Aspiration is the unintended inhalation of solid and/or fluid substances, aspirate, depending on its location and extent within the airways. The aspirate can cause atelectasis, inflammation, aspiration pneumonitis, bronchiolitis, or infection, aspiration pneumonia. Changes caused by aspiration are most commonly seen in the posterior portions of the lungs and predisposed to infection with anaerobic bacteria. Sequelae of aspiration, including scarring and bronchiectasis, can be seen in variable anatomic locations but tend to follow the direction of the gravity. Atelectasis pathology. Atelectasis is a partial or complete collapse of the lung. Atelectasis can be caused by loss of negative pressure in the pleural space and/or by compression of the lung parenchyma, for example, by pleural effusions, by resorption of air following obstruction, for example, by foreign body or neoplasm, or by an increase in alveolar surface tension, for example, by surfactant dysfunction. Atelectasis shows a lower volume and higher attenuation than normal lung tissue, and is often associated with abnormal displacement of fissures, bronchi, vessels, hyperinflation of adjacent lobes, or obscuration of cardiac and mediastinal interfaces. Atelectasis pathology. Lobar. Atelectasis of an entire pulmonary lobe. Linear, formerly plate-like, band-like, descriptor for local atelectasis with a linear, plate-like or band-like shape, often seen in dependent lung regions, paralleling the hemidiaphragms on chest radiographs and chest wall on CT examination. Of note, the geometric definition of line refers to an one-dimensional structure, while the cross-sectional appearance of an atelectasis may appear linear. The atelectasis itself has greater dimensionality than a line. Atelectasis pathology. Lobar. Right upper lobe collapse due to non-small cell lung cancer of right upper lobe. Atelectasis pathology. Lobar. Left upper lobe collapse due to squamous cell carcinoma of the left upper lobe. Atelectasis pathology. Lobar. Arrow indicates right upper lobe collapse due to chronic endobronchial tuberculosis. Atelectasis pathology. Lobar. Arrows indicate the right middle lobe collapse due to chronic endobronchial inflammation. Atelectasis pathology. Lobar. Arrows indicate the right lower lobe collapse due to chronic endobronchial inflammation. Atelectasis pathology. Lobar atelectasis. Arrow indicates left lower lobe collapse due to endobronchial tumor. Atelectasis pathology, linear, formerly plate-like, band-like atelectasis. Arrow indicates linear atelectasis. Atelectasis pathology, linear. Both arrows indicate both lower lobe linear atelectasis. Atelectasis pathology, rounded portion of a collapsed lung associated with invaginated fibrotic pleura and thickened and fibrotic interlobular septa. Rounded atelectasis is consequence of chronic or recurrent pleural effusions as seen in asbestos-related disease, chronic cardiac or renal failure, or thoracic malignancies. At imaging, rounded atelectasis presents as a rounded mass abutting the pleura associated with adjacent pleural thickening. Distorted vessels and bronchi converging toward atelectasis can have a curvilinear appearance, comet-tail sign. It is most commonly seen in the posterior lower lobes. Atelectasis pathology, rounded. Arrows indicate rounded atelectasis. In other words, comet-tail sign. Atelectasis pathology, segmental. Atelectasis of an anatomical segment of the lung. Subsegmental. Atelectasis of an anatomical subsegment of the lung, which often appears linear. Atelectasis pathology, subsegmental. Arrows indicate subsegmental linear atelectasis. Atelectasis pathology, subsegmental, linear. Both arrows indicate subsegmental, linear atelectasis. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Ator sign, pathology descriptor. The Ator sign is the descriptive term for a focal ground glass opacity surrounded by a partial or complete ring of consolidation. It is a nonspecific sign originally described in organizing pneumonia and reported subsequently in various other lung diseases. A synonymous term is the reversed halo sign. Ator sign, pathology descriptor. Arrows indicate Ator sign in axial and coronal CAT scan. Ator sign, pathology descriptor. Arrow indicates Ator sign in organizing pneumonia. Agigoesophageal recess. Anatomy. Agigoesophageal recess is right posterior mediastinal recess into which medial part of right lower lobe extends. It is limited cranially by agigus arch, posteriorly by agigus vein and pleura anteriorly to vertebral bodies, and medially by esophagus. On frontal radiographs, medial part of the recess can be seen as a vertically oriented interface between the right lower lobe and esophagus, and superior part of recess is seen as a smooth arc with convexity to the left at interface with agigus vein. Distortion or obliteration of interface can reflect the disease, for example, adenopathy or neoplasm. At CT, the recess merits attention because small lesions located in recess are often invisible on radiographs. Agigoesophageal recess anatomy. Arrows indicate the agigoesophageal recess on axial CT scan and Frontal chest radiograph. BLEP pathology. A BLEP is a circumscribed air-containing cystic structure, exclusively pleural in location and usually sub-centimeter in size. BLEPs have been associated with small airway disease and occurrence of pneumothorax, notably in patients with active tobacco use. Small BLEPs are more readily appreciated with pathology than with the imaging. BLEP pathology. The arrows indicate two BLEPs on right upper lobe in the pneumothorax patient. BLEP pathology. The arrows indicate 2 cm BLEP on right upper lobe in the pneumothorax patient. Blood flow redistribution pathology. Blood flow redistribution is the non-specific term for changes in blood flow seen on both radiographs and CT examinations, reflecting regional redistribution resulting from pathologic conditions such as volume overload or chronic heart failure. Bronchial anatomy. Bronchioles are non-cartilage containing peripheral airways. Terminal bronchioles are most distal of purely conducting airways. They give rise to respiratory bronchioles, from which alveoli arise. Respiratory bronchioles allow gas exchange and branch into multiple alveolar ducts. Normal bronchioles are not visible using current CT techniques. However, in diseases of peripheral airways, bronchioles with thickened walls and/or plugged bronchioles can become visible as nodular opacities on radiographs and/or as tree-in-bud opacities on CT exam. Infection and inflammation of bronchioles are commonly referred to as bronchiolitis. Bronchial anatomy, tree-in-bud. Arrows indicate tree-in-bud appearance of tuberculosis patient. Bronchiectasis pathology. Bronchiectasis indicates a clinical condition of irreversible bronchial dilatation. In the absence of established chronicity, we recommend using the term bronchial dilatation. Bronchiectasis can be secondary to chronic inflammation, congenital, or caused by chronic infection and obstruction of more central airways. It is often accompanied by bronchial wall thickening and/or mucoid impaction. At CT, bronchiectasis manifests as dilatation of bronchs relative to accompanying pulmonary artery, signet ring sign, lack of tapering, presence of visible bronchi within 1 cm of pleural surface, tram tracking. Bronchial walls can be thickened and accompanied by scarring of adjacent parenchyma. Bronchiectasis pathology, tram track. Arrows indicate tram track of bronchiectasis in left lower lobe. Bronchiectasis pathology, tram tracking. Arrows indicate tram tracking on left lower lobe bronchiectasis on CT scan. Bronchiectasis pathology, cystic bronchiectasis. Arrows indicate cystic bronchiectasis of right lower lobe in frontal radiograph and CAT scan. Bronchiectasis pathology, traction bronchiectasis pathology, dilatation of the bronchial lumen associated with thickened, irregular bronchial walls caused by fibrosis. This term should only be used in the context of fibrosis. Traction bronchiectasis pathology, dilatation of bronchioles within the central portion of the secondary pulmonary lobule, typically associated with fibrosis and honeycombing. Bronchiectasis pathology, traction bronchiectasis. 3 arrows indicate traction bronchiectasis in UIP patient. Bronchiectasis pathology, traction bronchiectasis. Arrow indicates traction bronchiectasis in ILD patient. Bronchiectasis pathology, traction bronchiectasis. Arrows indicate traction bronchiectasis. Traction bronchiectasis. 2 white arrows indicate traction bronchiectasis of right lower lobe. Bronchiectasis pathology, traction bronchial ectasis. Arrows indicate traction bronchial ectasis in ILD patient. Bronchiectasis pathology, traction bronchial ectasis. Arrows indicate the traction bronchial ectasis in interstitial lung disease patient. Bronchial ectasis. Arrows indicate bronchial ectasis. Bronchiectasis pathology, signet ring. Arrows indicate signet ring sign of bronchiectasis in right lower lobe. Bronchocele pathology. A bronchocele is a focal bronchial dilatation, often with mucoid impaction. Bronchoceles can be either congenital, for example in bronchial atresia, or caused by retained secretions or proximal obstruction, for example by an endobronchial tumor. At CAT scan, bronchoceles are typically branching V or Y-shaped structures that may have a finger-like appearance. In bronchial atresia, the surrounding lung parenchyma can have low attenuation because of reduced ventilation and thus decreased perfusion. Bronchocele pathology. Arrows indicate bronchocele with mucoid impaction in right lower lobe. Bronchocele pathology. Arrows indicate bronchocele with mucoid impaction in right upper lobe of bronchial atresia patient. Bronchocele pathology. Arrows indicate Y-shaped bronchocele with mucoid impaction in right lung. Bronchocele pathology. Arrows indicate V-shaped bronchocele with mucoid impaction in right upper lobe. Broncholith pathology. A broncholith is calcified material within bronchial lumen, generally caused by erosion of a peribronchial lymph node into the lumen, and most commonly a result of previous granulomatous infection. Broncholith manifest when calcified lesions directly adjacent to or within bronchial wall erode into the lumen. They can be accompanied by distal atelectasis, bronchiectasis, or mucoid impaction. Broncholith pathology. Arrows indicate broncholith and bronchial dilatation. Bronchomalacia pathology. Bronchomalacia is mechanical weakening of bronchial cartilage, either congenital or caused by chronic inflammation and damage, leading to excessive bronchial collapsibility of approximately 70 to 80% of original luminal diameter, subsequent ventilatory impairment. Excessive collapsibility is best confirmed with a dynamic CT performed during first expiration. Bronchomalacia is often associated with the same phenomenon in tracheal malacia and can be accompanied by thickening of airway walls. Of note, a substantial degree of collapse may also occur in healthy individuals. Bulla, plural, bullae, pathology. A bulla is a circumscribed air-containing cystic structure in the lung parenchyma, lined by a thin layer of collapsed lung parenchyma. It is caused by dilatation, destruction, and conference of air spaces distal to terminal bronchioles. At imaging, a bulla typically appears as a rounded lucency with a very fine and usually smooth wall. Bulla, plural, bullae, pathology. Arrows indicate the bullae of the right upper lobe. We have enjoyed this wonderful painting of Botticelli, the Primavera, the Spring. Please pay more attention between the space between Cupid and the Venus in the center of the painting. What do we see? Or what do you see? Do we see chest radiograph? You quit smoking? You did a great job of this year. Congratulations. See you soon on part 3.